Hello and welcome to GP Notebook. My name is Kate Chesterman and I'm a salaried GP in South Norfolk, and I've also recently been co-hosting the GP Notebook education study groups. And today we're going to be discussing the topic of mastalgia, and I thought we would start with a case study. So this is the case of Laura, and Laura is 38 years old and she phones you up. We're still living in the world of doing a lot of telephone triage, so she's on the phone and she tells you that she's had a 4-month history of intermittent breast pain. She hasn't noticed any pattern to it, she's done a good examination and she can't feel any lumps. She's usually fit and well, but she does tell you that her mother had a history of recurrent breast cysts. Her only current medication is a combined oral contraceptive pill, and she's a non-smoker and she drinks a reasonable amount of caffeine but no alcohol. So what would you do next? Are you happy that she's done a thorough examination, and would you reassure her and give her a patient information leaflet about mastalgia? Would you want to consider changing her oral contraceptive pill, maybe trying a different formulation? Would you bring her in and examine her? Or are you concerned about her breast pain and the length of time that it's gone on for, and would you consider a referral to secondary care, either a routine referral, or maybe you're worried about the possibility of cancer and you'd want to consider an urgent referral to the Rapid Access Breast Clinic? Well, I think these are all interesting options, and we're going to discuss them more a little bit as we go through this talk, and hopefully come to a good consensus about what would be a good option for her. But in the first instance, I think what a lot of people would do, and what we've done in this case, is to bring her in and examine her. So we do a thorough examination ourselves, and we're also happy that there's no cause for concern and that we can't find anything untoward. So what do we do now? Are we now happy to reassure her and give her that patient information leaflet? Do we now want to consider changing her pill, or maybe giving her some advice, so suggesting she reduces her caffeine intake, maybe advise her to get a well-fitted bra, or maybe even to try some extra medication such as evening primrose oil? Or are we still concerned about this breast pain, even in the absence of any findings on examination? And do we want to consider that referral to secondary care, either routinely or urgently? So again, some interesting options to think about, and probably some questions that are going through our minds when faced with cases of mastalgia. And as I say, we're going to go on now and discuss some of these options and try and understand what and why the best option would be for her. So this talk is really based around an article that was produced in the British Journal of General Practice just last year, so back in 2020, which was really helpful in guiding us in how to assess and decide who to refer when faced with cases of mastalgia. And I've also made reference to the NICE guidelines on suspected cancer, recognition and referral, and also a NICE clinical knowledge summary on cyclical breast pain that I found really helpful. And the first thing to say about mastalgia is that it really is very common. So about 70% of women will experience mastalgia in some form or another throughout their lifetime. And it's also a common reason for referral to secondary care as well. And the article actually quoted that 41% of referrals to the breast clinic are due to mastalgia. And I think, as we find as we go through this talk, that maybe we could reduce that amount safely and appropriately with effective primary care management. The other important thing to say about mastalgia is that it's not exclusive to women and that it can occur in men as well. When mastalgia occurs in men, it's usually due to gynecomastia. Now, I'm not going to talk much more about gynecomastia or men's breast pain in this discussion. If this is something you'd like to know a little bit more about, then we are hoping to produce a podcast on gynecomastia very soon. And depending on when you're looking at this video, it may already be available, so it'd be worth checking that out. The other really important take-home message from these articles is that mastalgia alone, in the absence of any concerning findings on history or examination, is not associated with breast cancer. And I think this is a really reassuring message, not only for us, but also for our patients as well. And I think that they'll find that a very helpful statement that you can say to them. And the other thing to be aware of with mastalgia, and this might be an obvious thing to say, but just remember that it's a symptom rather than a diagnosis, and that actually there are a whole host of reasons why a woman may experience pain within or around her breast. And we're going to go on and look at some of these on the next slide. But something that you can do that can be really helpful to try and distinguish between different types of mastalgia is it suggests that the woman completes a pain diary. And this can be a really effective tool in letting her see whether there are any patterns emerging to her symptoms and therefore what might be underlying it. And what we're really asking her to do is to grade her pain on this breast pain diary. So the severity of it, where she's feeling it, and any associated features. And to do this on a daily basis over 2 to 3 cycles. And as I say, this can give us more of an understanding about what might be causing her symptoms. Because as I've suggested, there are a lot of different reasons why a woman may be experiencing pain in or around her breast. And these can be divided into either true mastalgia that occurs within the breast itself, or extramammary causes. The extramammary causes are actually the most common causes, and these are, as I say, more common than true mastalgia, and there are lots of different reasons. And when we think about the different structures that are around a woman's breast, it's not surprising that there are a lot of different reasons why a woman may experience pain in this area. So extramammary breast pain could come from the chest wall. It could be musculoskeletal pain. It could happen as a result of, say, trauma or maybe costochondritis. If she's got pain with exercise, then we may want to think about something like ischemic heart disease. If the pain's worse after eating, then maybe this is gallbladder pain or gastroesophageal reflux. Or if it's associated with a rash, we might want to consider a condition such as herpes zoster. So that history and examination is going to be really important. Extramammary pain is usually, but not always, unilateral. Depending on what's causing it, it may be worse with activity. And again, particularly if it's musculoskeletal pain, it might be reproduced by pressure on the chest wall. And it's often felt either very medially or laterally within the breast. So there are extramammary breast pains. And then we've got the true mastalgias, the pain that actually arises from within the breast tissue itself. And again, these can be further subdivided into either cyclical or non-cyclical breast pain. Cyclical breast pain is more common than non-cyclical and accounts for about 2/3 of cases of true mastalgia. And as suggested by the name, this is influenced by hormonal changes and where in the women's cycle she is. The woman usually experiences breast pain in the luteal phase of her cycle. So this is in the last couple of weeks of her menstrual cycle leading up to the onset of menses, and the pain usually settles with or soon after the onset of her period. It's generally quite poorly localised pain and can extend to the axilla and is often felt bilaterally, but not always. And because it's associated with hormonal changes, it's less common after the menopause. So this is often in our younger cohort of women. Non-cyclical breast pain is less common and accounts for the final third of true mastalgias. This is more common in women with large breasts, but also with some other breast conditions as well, such as cysts, infections like mastitis or breast abscesses, previous breast surgery, or it can be associated with thrombophlebitis or pregnancy. This is not related to hormonal changes, so we don't see that cyclical pattern, and often the pattern can be really very variable. This pain is usually felt unilaterally. Again, not always, but it is more common to feel it unilaterally. So how are we going to assess our women with breast pain? Well, we've already alluded to the fact that the history is going to be really important, particularly often when we're looking at causes of extramammary pain, but also in trying to distinguish whether there's a cyclical pattern. We also want to know whether there's any other breast symptoms. So is the woman aware of any lumps, any nipple discharge, any symptoms within her axilla? Is she on any hormonal medications? Is there any possibility of pregnancy? And also, is there any family history of breast disease? And we do want to do a really thorough examination as well. So we want to make sure we're examining all 4 quadrants of her breast as well as the subareolar region. We're looking not only for lumps, but any skin changes that we can see as well, any nipple changes, and checking for any lumps within the axilla or the supraclavicular areas. One tip that I found quite helpful is to move the woman into a lateral semi-recumbent position. So we're asking her to lie back, but also to turn slightly onto one side. The advantage of this is that it moves the breast tissue away from the chest wall and allows direct palpation of the chest wall. And if on doing that we reproduce the woman's pain, then we can be very reassured that this is musculoskeletal pain and allow us to give that reassurance to our patient as well. Those skin changes that I mentioned, there are a couple in particular that I think we probably want to be looking out for. So the dimple changes associated with peau d'orange, and also looking for an eczematous rash around the nipple as well. This typically doesn't respond to topical treatments such as steroids and can be associated with Paget's disease and breast cancer. The other thing to look out for is signs of infection, so mastitis and breast abscesses. And also be aware that inflammatory cancers can look very similar to mastitis, but aren't usually associated with pain and don't respond to antibiotics. So if you've got a lady who looks like she's got mastitis, but she's not getting better with antibiotics, and particularly if it's not associated with pain, because mastitis is usually a very painful condition, then you'd want to be considering an urgent referral to rule out possible inflammatory cancer. Now, we've talked a little bit about referral, and we've already said that mastalgia alone is not really associated with breast cancer, and the NICE suspected cancer guidelines back us up on this as well. So they say quite clearly that breast pain on its own is not a criteria for an urgent referral. It has a positive predictive value for breast cancer of less than 3%. However, it is important to understand when we should be referring women urgently. And again, this NICE guideline, I'm sure you've looked at it, is very clear on who we should be referring and gives us really good guidance. So anyone over the age of 30 years old with a unilateral breast lump, whether or not it's associated with pain, should be referred under a 2-week wait referral. Similarly, any women over the age of 50 with unilateral nipple discharge, nipple retraction or any other nipple changes should also be referred urgently. And we would also want to be considering an urgent 2-week wait referral for those skin changes we've already mentioned, or for anyone over the age of 30 years old with an unexplained lump in their axilla. It's also important to consider urgent referrals for women who have infections of their breast that are not responding to antibiotics, or if they're systemically unwell with it. And then we would also consider a non-urgent referral for younger women, so women under the age of 30 with unexplained breast lumps, again, whether or not they've got any pain associated with that. But if a woman doesn't fit into any of those criteria, like Laura, our case study at the beginning, she's in a younger age range, she's only got pain with no other signs or symptoms that we're concerned about, then what can we do to help support her? Well, that careful examination and explanation is really important. It's the cornerstone to so much of what we do in general practice, and it really has a place in the management of mastalgia. If we can reassure women that we don't believe that their pain is associated with breast cancer, and also that it usually resolves spontaneously, that can provide a huge amount of comfort and reassurance to our patients. Other things that can be suggested to try and help them are a well-fitted bra, and also particularly in women with larger breasts, a soft support bra at night can also give them some comfort. But there is very little evidence for dietary modifications, so we used to recommend things like reducing caffeine intake, and actually these are currently not recommended by NICE due to a lack of evidence. So we might suggest these things to Laura. As I say, we might suggest that she gets a well-fitted bra and just reassure her. But if her symptoms aren't settling down, then is there anything else we can add in? And yes, there is. There are some pharmacological managements as well. And really, topical non-steroidals should be considered our first-line management for women with mastalgia. The article that I'm quoting really mentioned piroxicam and diclofenac, but I think any topical non-steroidal of your choice or that suits the woman would be absolutely fine. If that's not sufficient and she's still experiencing symptoms, you can switch the topical non-steroidal for an oral non-steroidal as long as it's safe and appropriate to do so, and also consider adding in paracetamol. But there are a lot of other medications or changes in medications, again, that have been recommended in the past that are currently not supported by NICE due to a lack of evidence. And these are things such as switching somebody's oral contraceptive pill for a different brand, trying evening primrose oil, trying a progesterone-only pill, antibiotics unless there's any evidence for infection, And also probably less common considerations now, but things that have been tried in the past, such as diuretics, pyridoxine, tibolone, vitamin E. All these things are currently not recommended by NICE. So as I say, really our main managements in primary care are supportive, well-fitted bras, lots of reassurance, and also thinking about those first-line pharmacological therapies, so topical non-steroidals, possibly switching to oral non-steroidals or adding in paracetamol. Now, we've said a lot that we don't need to be doing urgent referrals for these women because we're concerned about breast cancer. But is there any reason why we would want to be considering a referral to secondary care for a woman purely with mastalgia? And actually, yes, there is. So it would be worth considering a referral to a breast specialist, and this would be a routine referral rather than an urgent one. But if that pain is severe enough that it's affecting your women's quality of life or their sleep, and if they've not responded to those first-line therapies for 3 months, then absolutely it would be worth a referral to secondary care. And really the reason we're referring them is for consideration of other treatments such as tamoxifen or danazol to try and help relieve their pain. Now, I just wanted to finish off by giving you a couple of resources. So the first is a link to a pain diary. It's one that I give out to women who are suffering with mastalgia that I found very helpful in guiding them through how to grade their pain. And I've also done a link to a patient information leaflet as well. I've stuck to the NHS website for this one. I think actually it's a very good leaflet, and it really mirrors a lot of that reassuring words that we're using with women who are presenting purely with mastalgia. I hope this has been helpful, and I hope you found this video useful, and thank you very much for listening.